So I'm going to begin with disclosure. I am a consultant to McKay Critical Care, and I do receive financial benefits in the form of royalties on patents because I'm a co-inventor of some of the technology. Now, a lecture on NAVA and diaphragm electrical activity wouldn't be successful without a slide about spontaneous breathing and the chain of events that are involved. Is there a pointer? All of you know that the origin of spontaneous breathing is in the respiratory centers, and that signals travel down the phrenic nerve. This activates the diaphragm. Diaphragm contracts after it's activated. This expands the chest wall and the lungs, generates pressure and flow the airway, and then we have the next step, which is the gas exchange. And when we talk about the respiratory centers, we're talking about the brainstem here and the respiratory centers that lie in the medulla and the pons. There's also, from a voluntary control of breathing, you have central respiratory drive from the higher respiratory centers. They converge into, and for the diaphragm point of view, into the motor neuron, which is the phrenic nerve, which stimulates the diaphragm. This slide shows all the feedback mechanisms that are actually feeding back to the respiratory centers continuously. So we've already briefly talked about stretch receptors and irritant receptors in the lungs. You have receptors in your joints. You have receptors in your muscles. You have feedback from your blood gases, from the peripheral chemoreceptors, the central chemoreceptors. Sedation will also affect your respiratory center output, and you have other factors such as pain, emotional stimuli that can also affect what's coming out of the respiratory drive through the phrenic nerves. Because my talk is going to talk about differences between infants and adults, I thought I'd just briefly talk to you about some of the important differences from the EDI point of view. Babies, especially the premature ones, have surfactant deficiency and compliant chest wall, which makes that the lung has a tendency to de-recruit, as we talked about just a few minutes ago. They have very strong vagal reflexes, and they have apnea of prematurity. So if you're having apnea and you're using respiratory drive to control a ventilator, how does that affect the situation? So we'll talk a little bit about diaphragm activation. And just to clarify, the EDI that you're looking at on the monitor is actually an electromyogram signal. So it's the electrical signal that we're picking up from an activated muscle. So this is just a very simplified schematic to show you. Here you have skeletal muscle. What you do is you place electrodes on the muscle, and when you measure the voltage difference between the two electrodes and you plot it versus time, this is the type of a signal that you get. That's just a schematic. And you all know that the way that you increase muscle force is by recruiting motor units or by increasing the firing rate of already activated motor units. So here you have a picture that shows two motor units. And if you were to activate just one motor unit, you would get something called a single motor unit action potential. But as you increase the firing rate of that motor unit and more motor units, you start to sum up all these motor unit action potentials that you're measuring, and you get your waveform. So this signal, the diaphragm EMG, the EDI activity, is just a reflection of motor unit recruitment and increased motor unit firing rate. And you can see here the early work of Lourenco, where he measured in dogs the phrenic nerve activity with needles and the costal diaphragm EMG. And you can see how nicely the diaphragm activity reflects the phrenic nerve activity. And you can see here on the right, when he measured with an esophageal electrode the diaphragm activity and the phrenic nerve activity during resistive breathing in dogs, he found a proportional linear relationship. So yes, when people ask us, does the diaphragm activity reflect the phrenic nerve activity? If you have a good neuromuscular transmission, it does reflect the signal, the final signal coming out of the brain. Just to let you know that we've also done a lot of mathematical modeling on firing rate and motor unit recruitment. And just to simplify the axes for you, what we found in a mathematical model is that if you look at the amplitude of the EMG signal or the EDI waveform, it is linearly related to diaphragm activation. So it's linearly related to recruitment and firing rate. Also, the diaphragm activity is, under certain circumstances, such as optimal length, related to the force. So this is data that's not published that Christer measured in dogs, and you have the diaphragm EMG bursts, and here you have the force measured directly from the muscle. And that's in dogs. And here you have a paper that we published in 1998 where we also looked at the relationship between the amplitude of the diaphragm activity and diaphragmatic force. And we also found in these 6 healthy subjects that there was more or less a linear relationship between the EDI and the force output of the muscle. So how do we measure the diaphragm activity? And I found this beautiful slide on the internet. You can see here, this is the diaphragm from a side view. Here you have the spinal cord. And you can see here the esophagus, which actually pierces right through the diaphragm. And you have here the costal portion of the diaphragm. And here you have the vertebral, or the crural part, which is actually muscle that forms a scarf around the esophagus. So it makes it, by taking advantage of the anatomy, we're able to pick up the EMG signal from the diaphragm inside. So the way that we measure the diaphragm activity, I'm going to say EDI from now on, is we actually taken advantage of the anatomy, and what we've done is we've mounted miniaturized sensors on a conventional nasogastric orogastric feeding tube. I'm sure all of you have seen this before. We use a multiple array of electrodes so that as the diaphragm is moving during breathing, we can always capture the best position. Just wanted to remind everybody that the method for signal processing was published in a consensus document in 2002 in the Blue Journal. And for those of you who are brave enough to read all the details of the signal processing, you'll find it here. And just to briefly take you through some of the steps, this is data taken from a healthy subject who is doing 1 inspiration from FRC to TLC. This slide shows you the raw EMG signals as they were recorded, and you can see that there's ECGs and that there's quite a lot of motion artifact. And then you can see after filtering that we have a more stable signal, and from this we're able to trace the movement of the diaphragm throughout the inspiration using what we call the double subtraction technique. Then we have an accumulated signal, and we calculate the root mean square from this, and then we just connect the dots basically, and we have our EDI waveform. So there's a lot of signal processing in that little black box on the side of the servo-I ventilator. And that actually took us years of work. Right, Christer? That was 3-4 years of work. So now we have at the bedside in real time the EDI waveform. The top 4 tracings here are a condensed version of the 8 electrode pairs. And then you have the process waveform here on the bottom. So it's just like a waveform for airway pressure or tidal volume. There's an upward phase, which is the neural inspiratory phase. It rises to a peak. This would be the part of the breath where you would have increasing motor unit recruitment and increasing firing rate. And then you start to have de-recruitment or less firing rate, so deactivation of the diaphragm. So you have a waveform, and from this waveform you can actually quantify the peak value as well as the baseline or the minimum value. So let's look a little bit at what makes the EDI peak increase. This is a paper that Christer published in 1998, and it shows the diaphragm electrical activity waveform and tidal volume in a healthy subject and 2 groups of patients who have diaphragm weakness. And what you'll notice is that for the same tidal volume, this is a healthy subject sitting at rest with a mouthpiece. COPD patient as well as sitting with a mouthpiece. It's not on a ventilator. But what you'll notice is that for the same tidal volume, that the COPD patient, who is probably hypercapnic and hyperinflated, requires about 5 or 6, or is it 8 times as much diaphragm activity as the healthy subject does to compensate for his worsened respiratory status. So what else do you think can make the diaphragm EDI peak go up? reduced level of assist, increasing the respiratory load, weakness of the diaphragm, increased CO2, reduced sedation, and there's probably many more. I just wanted you to get a feeling about that signal and what makes it go up. You can also see here for the EDI min value. This is a paper taken by a slide taken from MRO study in 2006. And you can see here, this is for an infant on SIMV, motive mechanical ventilation, at a very low rate. This is just the spontaneous breathing part. It's an intubated baby. And you can see here, this is a PEEP of 5, that there is a baseline activity reflected by this red line. And then when you remove the PEEP, so you can see here the PEEP went down to 0, that there's an instantaneous increase in the baseline. So the EDI min has increased when we remove the PEEP. And this is what we talked about before, which is that there's probably de-recruitment of the lung, deflation-sensitive receptors feed back to the brain and say, open me up, and don't relax in between breaths. Keep the lung open. And then when we put the PEEP back on, we were able to bring the EDI min back to where it was. This is a vagally mediated reflex because we've done this in rabbits with lung injury, and this reflex goes away. So we're pretty sure that de-recruitment below FRC and liquid and edema in the lung are responsible for increasing the EDI min. This is a slide just to show you the differences in the EDI pattern over like a 2-minute period. So you can see here clearly that the adult EDI waveform, although still a little bit variable, returns to baseline between breaths. And this is a typical pattern for a premature baby. So you have a lot of tonic activity, you have intermittent sighs, brief respiratory pauses. So clearly there are differences in their vagal reflexes and their responses are affecting the variability. From the EDI waveform, you can also get information about neural timings. I'm sure we're going to have a lot of discussions about cycling off of NAVA and why we use 70%. And I just wanted to show you the differences between an adult and a baby. Is that this is the EDI waveform for a 20-second period in an adult. And you can see here that the shape of the waveform tends to be more of a slower increase and then a rapid decline. So whether you put the cycling off right at the peak or at the green bar indicates a 70% cycling off, I believe, that there's very little difference between where this dashed line is and the green bar to the right. But you can see in the babies, for example, here, if you were to take this as the peak and it would cycle off the ventilator here, it would be too early. You actually need to prolong that a little bit. So I'm going to show you in my next slide a little bit more. But clearly the difference in breathing pattern, here you have an upward rise and then a more slower decline of the diaphragm activity on the expiratory phase. So the controversy of neural TI, I still would like to hear what everybody's opinion is about this. Here you have data taken from Benora in cats. This is a spirogram, so you have inspiration and expiration defined by tidal volume. And what I'd like to just show you is that if you look at raw diaphragm activity recorded, you can see that there's a progressive increase throughout the inspiration. However, the diaphragm activity does not necessarily shut off completely at the end of the inspiration. So there is a lot of diaphragm activity after its peak that needs to be supported. This is an excellent review on motor control of respiratory muscles by Butler. And I just want you to focus up here on this graph. And I know it looks a bit scary, but all it's showing is the motor unit activity. They use needles in the diaphragm. And this is the inspiration. Right here it starts, and this is where the flow starts to reverse. And you can see here that the diaphragm is still active in humans after expiration has started. So I went through all the literature to see where people are defining neural inspiration. And I gave up after a while on the people who define neural TI to the peak of the EDI because the list is much longer than the few who actually define neural TI to 70% of peak. So we can have a discussion later about the definition of neural inspiratory time versus when you should cycle off the ventilator. The published data also shows, if you're curious, about what the mean EDI values are in adults and in babies. And if you look at the data that I was able to put together, out of 149 adult patients who are ventilated on NAVA at the adequate or comfortable level or level that they studied, Although mixed population, out of 149 patients, the mean value was 10.4 microvolts. When I went through all the infant studies on NAVA, 28 reported the EDI values. The EDI peak values on average 10.8, very, very similar numbers, despite the fact that the catheters are different. The adults use a 16 French catheter. The interelectrode distance is 16 millimeters. And the babies, that's a mix of the 8 and the 6. So you have to keep all that in mind. The neural respiratory rate is about double in the babies compared to the grown-ups. And from the published literature, looking at variability, so using the coefficient of variation, the babies as well are twice as variable in their diaphragm activity than an adult. So let's talk a little bit about what no EDI means. Here you have a slide taken from a premature baby. And you can see here the ECG, which is just every bar up here represents the heart rate. And this is the diaphragm activity waveform. And you can see here, after a normal period of breathing, that the diaphragm is silent. But you can also see that it's accompanied by a reduction in heart rate at the same time. And then when the baby is aroused, the heart rate returns. I think that's quite incredible. So you can actually, from no EDI, also monitor the babies in terms of their apnea of prematurity and the heart rate and the saturation. I think Paolo's going to talk about sedation, but we actually observed a case where we gave a little bit of morphine to a baby and we actually eliminated all the diaphragm activity. Here you have data from University of Virginia that shows the diaphragm activity for 2 breaths during NAVA, and then they switched the mode to PRVC, and you can see here that just by changing the mode of the ventilator made the diaphragm activity go away. So I think no EDI is also something to think about and that we can learn what's going on. We're going to hear a lot about patient-ventilator interaction today. So the EDI waveform can be superimposed on the ventilator pressure waveform, as you can see here, and you can get an idea about interaction between the patient and the ventilator. So in summary, the electrical activity of the diaphragm is a physiological signal representative of central respiratory output and is normally present in spontaneously breathing subjects. The EDI is essentially a vital sign, just like the electrocardiogram. The EDI waveform has a characteristic cyclic or phasic pattern with quantifiable measurements of amplitude and timing. The EDI allows answers to the following questions, which is my patient breathing? So now you have, for the first time, a true patient signal. Does my patient respond to intervention? So if you're going to change the level of assist, does the patient respond? And is my patient synchronous with the ventilator? Thank you for the attention. I would just like to give a little bit of credit, obviously, to Krister and to Dr. Lindstrom and Dr. Freeberg, who are sitting up there. Can you guys give a wave? Because they are crucial to the development of the early phases of the technology and ongoing. And Norm, who is our technician since 20 years and has put down the catheter more times than he can count, I'm sure. So thank you very much.